Mr. Chairman. Thanks to the audience for taking the time to attend this presentation. I have no disclosures to make. Just a brief background about the uncontrolled non-hybrid donor transplant activity at Moradiellos. We are dealing mainly with mass-treated category type 1 and 2 donors. These donors are usually dead on the street after sudden cardiac arrest. According to our current protocol, they have to receive basic CPR under 5 minutes after the arrest and advanced CPR under 15 minutes. And if that is fulfilled, they can be considered potential lung donors, and they are transported to the donor hospital by the emergency teams. In certain conditions, they have to be intubated and ventilated, and continuous cardiac compressions are performed. On arrival at the donor hospital, topical pleural cooling is performed with cold Perfidex via bilateral chest tubes, and a final judicial and family consent is obtained prior to any more invasive procedures. And these procedures are actually the on-site evaluation by our own retrieval team. This clinical protocol started in November 2002, and so far we've done 38 bilateral lung transplants with this additional source of donors. What we have seen so far in these donors is that the lung transplants done with them have a higher degree of primary graft dysfunction, but a mid-term similar degree of bronchiolitis obliterans. So far, this is 2007 data, and we are reviewing it right now. It hasn't had neither the PhD or BOS any impact in survival. And thus, we consider these uncontrolled non-hybrid donors as a useful additional source of donors to increase the donor pool. Actually, a second program was started in Madrid almost a year ago at Hospital of the Octubre with very good early results using, again, these uncontrolled donors. So the clinical experience in Madrid with the evaluation of these type 1 donors is pretty much as follows. In our opinion, the current evaluation is limited in time, parameters, and precision. This evaluation includes the standard criteria. This is the medical history when it can be obtained, which is not always a chest X-ray, a bronchoscopy, the macro assessment, and more important up until now, an oxygenation test, which is done by infusing the pulmonary artery of the corpse of the potential donor with cold Perfidex and packed red cells, and measuring the oxygenation in that situation. What happens with this sort of evaluation is that there are some potential problems. We're evaluating cold 4 to 10 degrees lungs in a very non-physiological situation. Moreover, the correction for blood gas analysis for cold temperature is not very precise, and this is due to the fact that the algorithms used by the analyzers to correct for this temperature are not very precise at that extreme. Actually, most of the commercially available machines would only correct up until 15 degrees. So if you've got 7 or 6 degree perfusion temperature, the data you're obtaining might not be very precise, and we have got quite inconsistent results in our previous series. And of course, another limitation is that this is a one-time evaluation. You have a fixed amount of available donor blood to perform this assessment, and you can only do it once, and you have to decide right away if the lungs are acceptable or not. So in our mind, it's like looking at a very blurry picture of something moving very fast. And the goal of including a more precise chemical assessment was to switch to a very high-resolution picture, a global picture from very different sides of these lungs. Of course, the clinical usefulness of EVLP is in the evaluation of these lungs, recovery, and probably optimization, and we are dealing with evaluation here. We started our clinical program with EVLP evaluation of non-heart-beating donors in December 2009. It was an observational clinical trial, and we got ethics committee approval and informed consent from the recipients. And we also did some informative sessions to all the recipients listed to tell them that we had this project ongoing, if they were willing to participate. We had a great feedback from them and from their families. We're very grateful again to the Toronto group, who's been the leading group for some time now, and we pretty much use their same protocol. It has been described previously. I will not go into more detail. Just want to stress perhaps it's in bold letters there, the collapse test, just disconnecting the lungs from the ventilator. For us, it's a very informative test. You know, it's subjective, but seeing the lungs collapse nicely, homogeneously is very informative and gives us a great deal of confidence towards pursuing the procedure, the transplant. So we evaluated 10 donors. They were all male with a mean age of 45 years old. Most of them were smokers, some of them were cannabis consumers. There was no relevant prior medical history, and there's a question mark there because sometimes it's not possible to obtain any medical history at all, even from the family. So they're quite, unknown medical past of these donors. With the normal checks, X-ray in 60% of the cases and a bronchoscopy normal in 90%. We saw some degree of edema or infiltrating 4 out of the 10 cases. The Exvivo evaluation could be correctly or technically performed in all cases with a limited systolic PAP pressure, and we achieved the desired 40% cardiac output flow in all cases with the expected tidal volume. And in this series, in the 10 patients, the peak airway stayed below 15 centimeters of water in all cases. The average perfusion time was almost 4 hours and a half. And this was due to the fact that we decided to keep the lungs in the system, in the EVLP, until the recipient was ready for implant. So out of the 10, 4 lungs did not pass the evaluation. We decided to use a 400 millimeters of mercury total PO2 threshold as an extremely conservative threshold. And in these rejected lungs, there was a decline and trend towards deterioration in terms of oxygenation. We do believe that compliance is, as it has been mentioned before, a very sensitive parameter. It also gives an early warning. You start to see some decline in compliance even before that you would see decline in the oxygenation. And this is shown here concerning these 4 rejected lungs. So 6 out of the 10 lungs were considered acceptable, with a delta PO2 over 400, which remained pretty stable during the 3 tests. This is pretty much around 3 hours and a half and 4 hours. And so these lungs fulfill all our requirements for acceptance. This is the good oxygenation, stable or improving parameters, systolic PAP, and compliance. This is actually the graph for the compliance of these accepted lungs, in which we saw an increase in this compliance. And again, for us, this is very important, and it gives us a great deal of confidence towards accepting these lungs. The macro evaluation was also very positive, with no endoscopic edema in the bronch and a good collapse test, and also a good radiology in all cases with no developing radiographic edema. In this series of the 6 accepted lungs, the warm and cold ischemic times were very long. You can see the average there, the period for cold ischemia being exactly 8 hours on average, and then the second cold ischemia for the first and second lung, again with a perfusion time of around 4 hours and 30 minutes. Moreover, the total times between cardiac arrest at the donor and reperfusion of the recipient were extremely long. What we have sort of called cadaveric time for the first lung was almost 18 hours, and for the second lung, well over 20 hours and a half. And we are sort of used to dealing with very long ischemic times in our series of uncontrolled non-heartbeating donors, and adding this EVLP procedure really adds up to the time needed for the whole transplant procedure. The 6 recipients were not specifically selected from the waiting list. Like half of them, more than half of them, have moderate pulmonary hypertension. Patient number 2 had a very severe sarcopenia, and he developed that actually after he was on the waiting list. So it was quite of a late finding when we got to transplant the patient. And recipient number 4 had a multi-resistant Pseudomonas aeruginosa with a mild renal failure. And most of them were emphysema patients with one LAM and one bronchiectasis due to primarily ciliary dyskinesia. We compared the incidence of primary graft dysfunction at time point 24 hours to our historical series previously published by our group. And we did saw that in this group of Exvivo DCDs, the incidence of grade 2-3 PGD was lower than in the non-hybrid donors who had not undergone EVLP. This difference did not reach statistical significance, but it was a very interesting finding to us. Again, concerning the results after transplantation, you can see the mechanical ventilation time was in general quite limited for most patients. The ICU stay for the recipients are still alive. You can see the survival there. Two of them almost 1 year survival. And we had two recipients who failed. One was that patient number 2 I mentioned. He was extubated actually, and then he had to be intubated again. And the main problem we could assess with this patient was muscular insufficiency. He basically didn't have any muscle mass just to pull his new lungs. Patient number 3 developed on POD number 1 an aspergillus and mucor combined bronchopneumonia, and after struggling with this recipient for over 100 days, he finally and unfortunately died. Anyway, our 39-day survival in this very initial series is 100%. So what we learned in Madrid so far concerning EVLP, just a few thoughts I would like to share with you. It's a feasible procedure and it seems to be very safe for uncontrolled non-hybrid donors. It might decrease the incidence of severe primary graft dysfunction, and we would love to see that confirmed in future cases. We definitely believe that minor changes over time in EVLP parameters, trends, are significant, particularly the compliance one. Serial X-rays are very useful during any contrast, and you can assess both the presence or the developing of edema, as well as the presence of thrombi and underperfused areas with the lungs. Serial weight measures might be useful too, and we have some data on that which sort of confirms the rest of the trending parameters. And the clouds test being extremely subjective, of course, we haven't found a way to measure that. We find it very informative in terms of decision taking. As it has been mentioned before, accepting or rejecting these EVLP lungs after the evaluation is way much more than just the oxygenation, and a multi-parametric assessment is needed. We're not sure yet of the weight of each parameter, but we now know that you have to take everything into account and you have to analyze or see the whole picture before deciding on these lungs. So as a conclusion, this EVLP evaluation of uncontrolled non-hybrid donors provide a comprehensive and sustained over time evaluation of grafts prior to implantation, and in our mind this means sort of controlling uncontrolled donors. It may lower the incidence of primary graft dysfunction, and it may further justify the routinary use of uncontrolled non-hybrid donors in other groups. Thank you very much for your attention.